All right, the subtitle now says the biliary tract. In fact, we're going to have several subchapters. We're going to be talking about the liver, about the patient who presents with jaundice, and then eventually about the gallbladder and the rest of the biliary tract. So right now, the first group of vignettes are problems with the liver. Now, this is a surgical review, so it's going to be pretty brief because it's only going to deal with surgical problems affecting the liver. Vignette number 44. A 53-year-old man with cirrhosis of the liver develops malaise, vague right upper quadrant abdominal discomfort, and a 20-pound weight loss. Physical examination shows a palpable mass that seems to arise from the left lobe of the liver, and alpha-fetoprotein is significantly elevated. And let me read vignette 45 because there is a sort of a parallel there between the two. A 53-year-old man develops vague right upper quadrant abdominal discomfort and a 20-pound weight loss. Physical examination shows a palpable liver with nodularity. 2 years ago, he had a right hemicolectomy for cancer of the ascending colon. His carcinoembryogenic agent, CEA, had been within normal limits right after his hemicolectomy, is now 10 times normal. Both of these are descriptions of patients with cancer in the liver. The first one is primary liver cancer, which we see almost exclusively in people we already know have cirrhosis and subsequently develop a cancer. Alpha-fetoprotein is a marker there. And the second one, which is far more common in the US, is a patient who has metastatic cancer to the liver. And in this particular case, with the colon as the primary site, the marker for colon cancer that has recurred or metastasized is carcinoembryogenic agent, CEA. In both of these, the next thing you want to do is a CT scan to see the extent of the tumor in the liver so that it can be resected if it is resectable, or else we can do some palliative destruction of the tumor if we can. We move now to vignette number 46. A 24-year-old woman develops moderate generalized abdominal pain of sudden onset and shortly thereafter faints. At the time of evaluation in the ER, she is pale, tachycardic, and hypotensive. The abdomen is mildly distended and tendon, and she has a hemoglobin of 7. There is no history of trauma. On inquiring as to whether she might be pregnant, she denies the possibility because she has been on birth control pills since she was 14 and has never mistaken them. And that gives you the diagnosis, actually. You see, the reason for the question was that if you have a 24-year-old woman suddenly bleeding into the abdomen with no history of trauma, what you think of, in fact, is an ectopic pregnancy. And so whoever was doing the history here wanted to know, do you think you're pregnant? When the lady says, no, I'm not pregnant, I've been on birth control pills forever and ever, we then remember that one of the known, rare, but known complications of long-term use of birth control pills is the development of hepatic adenomas. They are not malignant, but they are very vascular, they can break and they can bleed. If you do a CT scan, it will show the blood in the peritoneal cavity, it will show the adenoma in the liver, and then we resect the adenoma. Vignettes 47 and 48 have something in common, but something to differentiate them. A 44-year-old woman is recovering from an episode of acute ascending cholangitis secondary to cholelocolitis. She develops fever and leukocytosis and some tenderness in the right upper quadrant. A sonogram reveals a liver abscess. You say, hey, I have the diagnosis already. What do they want from me? Well, they want management, because this kind of liver abscess in a lady who's had biliary tract disease, this is what we call a pyogenic abscess. And it needs to be drained like every other abscess in the body, which nowadays is done radiologically. So this lady needs radiologically guided percutaneous drainage of the abscess. But let's read the next one. A 29-year-old migrant worker from Mexico develops fever and leukocytosis as well as tenderness over the liver when the area is percussed. He has mild jaundice and an elevated alkaline phosphatase. Sonogram of the right upper abdominal area shows a normal biliary tree and an abscess in the liver. This is a different kind of abscess. A kind of abscess that is very common in Mexico, and therefore we see it in the US in patients who have what I call the Mexico connection. They come from Mexico, they used to live in Mexico, they retired to Mexico, they are migrant workers, whatever. And this is the amoebic abscess of the liver. So we are suspecting on this gentleman an amoebic abscess, which is interesting because among all abscesses we see in people, this one doesn't necessarily need to be drained to begin with, but it may be treated with metronidazole. To make the diagnosis, we rely on serologic studies, but it takes forever to get the answer. So here is a scheme. You suspect an amoebic abscess because this is a male, not with a background of biliary tract disease, but a background that he came from Mexico. You take the samples for the serology, but you don't wait. You start treating him empirically with metronidazole. If he improves, you continue. 3 weeks later, you get the answer from the lab, yes, this was an amoebic abscess. But if the patient isn't getting better within a day or two, then we drain it, because maybe it was not amoebic in the first place, or it was amoebic and was super infected, or it was amoebic and it was too large. All right? Every time we discuss this vignette, I have to warn you of a little trap. You might be offered as an option. Draw pus from the abscess, send it to the lab, ask them to grow the amoeba. Wrong answer. The amoeba doesn't grow in the pus of an amoebic abscess. It grows in the wall of the abscess, which happens to be why we can treat it with metronidazole. Have you ever asked yourselves, how come that in the 21st century, with lots and lots of antibiotics available, we still have to drain abscesses? Because in most abscesses, the pus has the bugs there safely away from where blood supply reaches, bringing the antibiotic. And so we have to drain abscesses because we cannot kill the bacteria in an abscess because they are protected where they are. But in the case of the amoeba is in the wall of the abscess, and therefore we can kill the amoeba with a metronidazole. All right, with that we move to the next little sub-chapter, jaundice. We're now going to be talking about patients whose presentation is they turn yellow. They have jaundice. A 42-year-old woman is jaundiced. She has a total bilirubin of 6, and the laboratory reports that the unconjugated indirect bilirubin is 6, and the direct conjugated bilirubin is 0. She has no bile in the urine. That lab combination is hemolytic jaundice. There is primarily, in fact, in this case exclusively, elevation of the indirect bilirubin, the one that has not been processed by the liver. Once it got to the liver, it didn't back up into the blood. We see no elevation of the direct bilirubin. This is classical for hemolytic jaundice. You now have to direct your workup as to why there is hemolysis. Let me move to the next. A 19-year-old college student returns from a trip to Cancun. 2 weeks later, develops malaise, weakness, and anorexia. A week later, he notices jaundice. When he presents for evaluation, his total bilirubin is 12, with 7 indirect and 5 direct. His alkaline phosphatase is mildly elevated. The transaminases are very high. That combination, alk-phos not very high, the transaminase is very high, that means hepatocellular jaundice. He probably picked up hepatitis in Cancun. You need to get the serologies to confirm, to find out what type of hepatitis. Again, the workup goes in that direction. And now we move to vignette 51. A patient with progressive jaundice that has been present for 4 weeks is found to have a total bilirubin of 22, with 16 direct and 6 indirect, and minimally elevated transaminases. The alkaline phosphatase was twice the normal value a couple of weeks ago and is now about 6 times the upper limit of normal. This is obstructive jaundice. And the signature from the lab is very high alkaline phosphates with not very high transaminases. And now your next move is a sonogram. The sonogram will show dilated intrahepatic ducts, dilated extrahepatic ducts, and probably gallstones, or maybe not. Let me move on to the next few vignettes and see where we are pretty sure it's gallstones and where in fact we think it's something else. And eventually we'll have a decision tree to repeat this. Vignette 52. A 40-year-old obese mother of 5 children, you all know what that means. That means biliary tract disease, that means gallstones, right? Presents with progressive jaundice, which she first noticed 4 weeks ago. She has a total bilirubin of 22 with 16 direct, 6 indirect, minimally elevated transaminases. The alkaline phosphate is 6 times the upper limit of normal. You know from the lab this is obstructive jaundice. She has a history of multiple episodes of colic right upper quadrant, abdominal pain brought about by ingestion of fatty food, which is classic for gallstones. So this is obstructive jaundice. You begin the workup with a sonogram. The sonogram you expect in this case will show stones in the gallbladder. And you have reason to suspect those are the reason for the obstruction. So after that, you do an ERCP, an endoscopic retrograde cholangiopancreatography, and then with that you remove the stone, and eventually you do a cholecystectomy. Let me read a couple of vignettes more, and we're eventually going to go to a decision tree here. A 66-year-old man presents with progressive jaundice, which he first noticed 6 weeks ago. He has a total bilirubin of 22, with 16 direct, 6 indirect, minimally elevated transaminases. The alkaline phosphate is about 6 times the upper limit of normal. He has lost 10 pounds over the past 2 months, otherwise asymptomatic. You know already this is obstructive. High alkaline phosphate is obstructive. You know the next move is a sonogram. Let's read it. A sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended thin wall gallbladder. And that last thing is bad news. That means the obstruction is from a cancer. Either a cancer of the head of the pancreas, a cancer of the ampulla of Vater, or a cancer of the common duct itself. So you do next a CT scan. If you see the tumor, you can biopsy. If not, if you don't see it on the CT, you do an ERCP to see it. Let's read vignette 54. 66-year-old man presents with progressive jaundice, which he first noticed 6 weeks ago. He has a total bilirubin of 22, 16 direct, 6 indirect, minimally elevated transaminases. The alkaline phosphate is about 6 times the upper limit of normal. He is otherwise asymptomatic. A sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended thin wall gallbladder. You know the meaning of that. This is a tumor. Except for the dilated duct, the CT scan is unremarkable. Well, that tumor was too small to be seen with a CT scan. Well, then we know what to do next, ERCP. ERCP shows a narrow area in the distal common duct and a normal pancreatic duct. This is a cholangiocarcinoma. This is a cancer growing out of the duct itself. Let me read 2 more, and then we look at the decision trees. A 64-year-old woman presents with progressive jaundice, which she first noticed 2 weeks ago. She has a total bilirubin of 12, with 8 direct, 4 indirect, and minimally elevated transaminases. The alkaline phosphate is about 10 times the upper limit of normal. You know that it is obstructive. She is otherwise asymptomatic, but is found to be slightly anemic and to have positive occult blood in the stool. A sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended thin wall gallbladder. Let's analyze this case. As you read it, when you read very high alk phos, not so high transaminases, you knew already obstructive. You knew the next move was a sonogram. You did it. Sonogram was there. The sonogram said dilated dogs, dilated thin wall gallbladder. You knew something more now. This is a tumor. But then you have another bit of information. She has anemia and positive occult blood in the stools. And always in medicine we try to find a single diagnosis that explains all the findings. You would not want to say, this lady must have a cancer of a pancreas that is giving her obstructive jaundice and a separate, different cancer of a colon that's giving her the anemia. It's better to find a single thing that explains everything. Well, let's think of the three cancers that can give you obstruction of a biliary tree. Cancer of the head of a pancreas, cancer of a common duct, cancer of the ampulla. Cancer of the head of a pancreas doesn't bleed into the lumen. Cancer of a common duct is typically very small, doesn't bleed into the lumen either. But cancer of the ampulla vater is an adenocarcinoma of the mucosa of the GI tract. That can bleed into the lumen. So a cancer of the ampulla is your best bet here to explain both the anemia with the occult blood and the obstructive jaundice due to tumor. And what this lady needs next is an endoscopy of the upper GI tract. She doesn't even need the ERCP. She needs only the E of the ERCP, the endoscopy, and they will see the tumor. Let me read the last of the vignettes of this series, and then we're going to go to a decision tree. We're going to remember all of these topics one more time. A 56-year-old man presents with progressive jaundice, which he first noticed 6 weeks ago. He has a total bilirubin of 22, with 16 direct and 6 indirect, and minimally elevated transaminases. The alkaline phosphatase is about 8 times the upper limit of normal. He has lost 20 pounds over the past 2 months and has a persistent, nagging, mild pain deep into his epigastrium and the upper back. His sister died at age 44 from a cancer of the pancreas. His sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended thin wall gallbladder. Let's analyze this one like we did the others. When you read this jaundice patient has very high alkaline phosphatase, not very high transaminases, you knew that was obstructive. When you read that he had lost 20 pounds, you knew he had a big tumor. You don't lose weight from a tiny BT carcinoma. When you lose weight from a cancer, you got big tumor. His sister died at age 44 from cancer of the pancreas. That's something that runs in families. And he has that persistent pain deep in the epigastrium and the upper back. This is the kind of pain you would have with a big cancer of the pancreas. And then finally the sonogram confirms that in addition to the dilated ducts, you see the big distended thin wall gallbladder. This is most likely a big cancer of the pancreas. And of course your next move now is a CT scan that will most likely show it and enable you to make the biopsies. Okay, let's review all this again. We're going to cut away from my face and go to where it's on the screen. A patient presents with jaundice. I want you to first look at the labs. If you see elevated, unconjugated indirect bilirubin and everything else is normal, that's hemolytic jaundice. If you have a patient with jaundice and you look at the labs and you see that both fractions of the bilirubin are elevated, the transaminases are very high, but the alkaline phosphatase is near normal, that is hepatocellular jaundice. Okay, we have another here. Patient with jaundice, you first look at the labs. If both fractions of bilirubin are elevated, the transaminases now are the ones that are near normal, and the alk phos is very high. That is obstructive jaundice. So what do we do next? We do a sonogram. You suspect obstructive jaundice, you start then with a sonogram. You see dilated intrahepatic and extrahepatic ducts. If you then look at the gallbladder. And when you look at that gallbladder, if it is shrunken and full of stones, the obstruction is probably due to stones. You do an ERCP, confirm the diagnosis, extract the stones, and then do a cholecystectomy later. But if you look at that gallbladder in the sonogram and it is thin wall, dilated without stones, you're dealing with a tumor. Well, let's continue then. Thin wall, dilated gallbladder without stones, you know that's a tumor. If there is no information about anemia or occult blood in the stool, do a CT scan. If the tumor is big, you will see it. And if the CT scan is negative, you do an ERCP. But on the other hand, if the patient has anemia, positive occult blood in the stool, then you do an upper GI endoscopy, because what you're suspecting is an ampullary cancer. We're now going to move into the subheading devoted to the gallbladder. Every one of our patients now is going to be the proverbial white, obese female in her 40s with many children, because those are the people who get gallstones. So let me start with vignette 57. A white, obese, 40-year-old mother of 5 children gives a history of repeated episodes of right upper quadrant abdominal pain, brought about by the ingestion of fatty foods and relieved by the administration of anticholinergic medications. The pain is colicky, radiates to the right shoulder, around to the back, accompanied by nausea and occasional vomiting, and physical exam right now is unremarkable. This is a lady who has gallstones, and she's giving a history of what we call biliary colics. You want to do a sonogram, it will demonstrate the presence of the stones, and you want to recommend elective cholecystectomy. Now vignette 58. 43-year-old obese mother of 6 children has severe right upper quadrant abdominal pain that began 6 hours ago. The pain was colicky at first, radiated to the right shoulder, around towards the back, accompanied by nausea and vomiting. For the past 2 hours, the pain has been constant. She has tenderness to deep palpation, muscle garden, rebound in the right upper quadrant. Her temperature is 101, white count of 12,000, liver function tests are normal. You recognize here, first of all, a fat female in her 40s with many children. You know that's the type of patient who gets biliary tract disease. Then you recognize an inflammatory process in the right upper quadrant. That's where the pain is, that's where the physical findings are. She has a fever, the leukocytosis. There are 2 inflammatory processes in people with biliary tract disease: acute cholecystitis and acute ascending cholangitis. In acute ascending cholangitis is an older, sicker patient with very deranged liver function tests. And so when we finished reading this vignette, the very last line said her liver function tests are normal or might have been near normal, and that makes the diagnosis. This is acute cholecystitis, not acute ascending cholangitis. What do you do next? Well, let me start with a general statement that will be helpful for the vignettes that follow. We said already apropos patients who present with jaundice and have a high alk phos that we always follow that with the sonogram. The same is true here. When we're thinking gallstones like we are here, we typically begin the workup with the sonogram. So now we're thinking this is acute cholecystitis, we do a sonogram. If the sonographer can see 3 things: gallstones, thickened gallbladder wall, and pericholecystic fluid, the sonographer will say the diagnosis is acute cholecystitis. We will put the patient on antibiotics, nothing by mouth, IV fluids, because most of these we can cool down and then remove the gallbladder at a convenient time. If the sonographer by chance came back very apologetic and said, I cannot find the necessary images to say that this is acute cholecystitis, no problem. We have another test we can do. We call the nuclear medicine people. We ask for an IDA scan. They inject the patient with a compound that might be Decida, Papida. They all end with Ida, so we call them generically an IDA scan. It's a compound that when you put it into the blood, the liver takes it and puts it into the bile. The nuclear medicine people make that compound radioactive. So once you've done that injection, wherever bile goes on that patient, radioactivity can be detected. When they scan the patient, if they see radioactivity in the liver, radioactivity in the common duct, in the duodenum, and in the gallbladder, the patient doesn't have acute cholecystitis. The gallbladder is functioning normal. But if the IDA scan shows radioactive material in the liver, in the common duct, in the duodenum, but not in the gallbladder, that gallbladder is acutely inflamed and not functioning. So we can make the diagnosis in most cases with a sonogram, if needed in a few rare cases with the IDA scan. We mentioned then that we go to the medical management. If the patient by chance doesn't respond to the medical management, we may need to do an emergency cholecystectomy. And often this is the case when the patient is a male with diabetes. So we are more likely to be successful with our medical management than the fat female with many pregnancies. And we're more likely to find ourselves operating in the middle of the night on the male diabetic that develops acute cholecystitis. Let's move to vignette 59. A 73-year-old obese mother of 6 children has severe right upper quadrant abdominal pain that began 3 days ago. The pain was colicky at first, but has been constant for the past 2.5 days. She has tenderness to deep palpation, muscle guarding, and rebound in the right upper quadrant. She has temperature spikes, 104, 105, with chills. Her white count is 22,000 with a shift to the left. Her bilirubin is 5. And she has an alkaline phosphatase of 2,000, which is about 20 times normal. This is acute ascending cholangitis. How do you recognize it? An older patient, much sicker, and that very classical diagnostic finding of the alkaline phosphatase extremely high. Let me make a little parenthesis here. Why is alkaline phosphatase useful in the diagnosis of biliary tract disease? Because alkaline phosphatase is made in the lining of the liver ducts. Anything that makes them angry, they make more. That is why patients with obstructive jaundice have a high level of alkaline phosphatase. Well, this patient that we're talking about now has actually pus in the common duct, acute ascending cholangitis, pus in the common duct. That makes the common duct very angry indeed, and so the alkaline phosphatase is extremely high. Now, this lady is very sick. This lady may die. This lady needs intravenous antibiotics to be put in the hospital intensive care unit. But what is going to save her life is immediate decompression of the biliary tract. She needs that pus out of there. And this is best done by the endoscopists who do the ERCPs. We call them, we say we have a lady who needs an ERCP, and if they begin to say to us, well, we can do one tomorrow, we say, wait a minute, let me finish. This is an old lady that has acute ascending cholangitis. There'll be a pause on that telephone line for about 10 seconds, and then they will say, we'll be right there. They know this is a problem that needs immediate emergency attention, and they do it, and do a very good job. We now move to vignette number 60. By the way, I'm going to repeat all of these in a little decision tree thing, so we have a second go around for these. Vignette 60. A white, obese, 40-year-old mother of 5 children gives a history of repeated episodes of right upper quadrant abdominal pain brought about by the ingestion of fatty foods, relieved by the administration of anticholinergic medications. The pain is colicky, radiates to the right shoulder, around to the back. accompanied by nausea, occasional vomiting. This time, she had a shaking chill with a colicky pain. The pain lasted longer than usual. She has mild tenderness to palpation in the epigastrium and right upper quadrant, and the lab show bilirubin of 3.5, alkaline phosphatase 5 times normal, and serum amylase 3 times normal. This lady has biliary pancreatitis. She's got a little gallstone that left the gallbladder, went through the cystic duct, down into the common duct, and is now impacted at the end of the common duct, impacted at the ampulla, obstructing both the common duct and the pancreatic duct. The obstruction of the common duct has led to the increased bilirubin, the increased alk phos. The obstruction of the pancreatic duct has led to an inflammatory process in the pancreas, evidenced by the amylase that is higher than normal. We typically manage this conservatively, hoping for the stone to pass, because we don't like to manipulate an angry pancreas. But if it doesn't get better within a couple of days, we may need to do an ERCP and remove the stone, and then eventually a cholecystectomy. Let me repeat all this. Let's go now to the words on the screen. So our patient is now a fat female in her 40s, and if you would excuse my exaggeration, with 55 children, okay? With right upper quadrant pain, and we think immediately this is biliary tract disease. After the initial labs, your workup always begins with a sonogram. If you discover gallstones in an otherwise asymptomatic patient, not the vignettes that we have been reading, the patient is completely asymptomatic, no surgery or treatment is indicated. But if there is a history of right upper quadrant colicky pain after fatty food, there is no pain right now, the physical exam is negative, you do the sonogram, and you advise an elective cholecystectomy, because this is now symptomatic gallstones. If you realize that there is an acute inflammatory process, right upper quadrant pain, tenderness, fever, leukocytosis, you check the liver function tests. Remember, we talked about that. If they are normal or minimally elevated, that inflammatory process is acute cholecystitis, most likely. You start with a sonogram, and if the sonogram shows gallstones, thickened gallbladder wall, and pericholecystic fluid, that is indeed the diagnosis. If the sonogram is not diagnostic, we do the IDA scan. Let's continue. If we do the IDA scan, if we see radioactivity in the liver, the common duct, the duodenum, but not in the gallbladder, we confirm the diagnosis of acute cholecystitis. And we start with our medical management first. MPO, intravenous fluids, antibiotics. She gets better, she gets an elective cholecystectomy when it is convenient. But if the patient is not responding to medical treatment, we do an emergency cholecystectomy. Here is an example of an IDA scan that demonstrates the liver and the biliary tract, the gallbladder, and the duodenum. Now, if we are dealing with an acute inflammatory process, right upper quadrant pain, tenderness, fever, leukocytosis, and we check the LFTs and we find that the bilirubin is elevated, the alkaline phosphatase is extremely high, and this is in an old sick patient. The diagnosis is acute ascending cholangitis. The sonogram will show dilated ducts, gallstones, without signs of gallbladder inflammation, because the inflammatory process is in the common duct, not in the gallbladder. This is a big emergency. Intravenous antibiotics, ICU, immediate ERCP to drain the pus from the common duct, and eventually cholecystectomy. Now, we have an acute inflammatory process, right upper quadrant pain, tenderness, fever, leukocytosis, and we check the LFTs. The alk phos is elevated, but the amylase and lipase are also elevated. Now we have biliary pancreatitis. The sonogram will show dilated ducts, gallstones in the gallbladder. No signs of gallbladder inflammation because the problem is in the pancreas. We start with conservative management. MPO, intravenous fluids, with a hope that the stone will pass spontaneously. But if it does not, we do sphincterotomy by means of an ERCP and a stone removal, and eventually a cholecystectomy will be needed.